Good afternoon, everybody. Can folks hear me okay?
Yes, Travis.
Excellent.
Yes, sir.
Welcome to July office hours. Can folks see the slide deck okay?
Looks
Yep.
good.
All
Yes,
right,
sir.
cool. All right, so we're rocking. Well, as usual, we got the session recording as well. And if folks have questions along the way, feel free to ask as usual. We'll have the chat function also, and we'll get things going here. Hope folks are having a good summer thus far, and we look forward to our agenda this month, and we'll get started. We're going to have a handful of policies and procedures. We haven't had any in the last couple months, so we've got some things to go through this month. We'll touch on the smart attachment documentation issue update, touch base on the plan of care compliance concern, where we're at with that. Redesignation audit, that's going on as well, as folks know. Just where we're at with VTQ transition. Touch on the NetSmart social support contact tab. We just want to touch on that as well. And then, as folks know, we have this new DOH 5055 form. Just want to do a reminder touch point on that this month again, because that is something that is coming down the pike, as folks are well aware of. So those are the topics this month. And then, of course, as always, if anybody has anything else they wanted to talk about, we can incorporate that into today's discussion. So with that, we'll go into our policies and procedures for the month. As you can see, there's a number that we have. But we'll have a HARP oversight policy that we'll go over, Health Home Plus, SMI, and AOT, Health Home Serving Children, HCBS, authorization, fee for service for members, homeless youth services, incident reporting, transfer process for Health Home Serving Children, OPWDD services, comprehensive waiver. So those are this month's updates that Jessica's going to be reviewing. And then there's a slew of upcoming policies that will be coming forth as well. So with that, Jessica, I didn't know if you wanted to take it from here for a little bit.
Yes, can you hear me?
Yes.
Okay, perfect. You can go to the next slide. So the first, well, all of the policies that we're going to review today are going to be pretty straightforward. There's not going to be any great updates to any of them. A lot of them were just an annual review. We had a little backlog with the plan of care audit that we did. So in August, you will start to see some policies come out that do have actual updates. And then we've also had some policies updated prematurely due to DOH change. So the first policy we have for you today is your HARP oversight policy. Again, annual review, no updates. We will fully update this policy once HCBS services have fully sunset. As we talked about last month on office hours, those HCBS services are going to be sunsetting, and those folks are going to be moved over to a core service that is comparable to the HCBS service that they are receiving. It's going to be quite a while before that is fully kind of sunset. So right now you want to go through the motions of offering those HCBS services. You can absolutely have the conversation that they will be sunset, and we really want to push our folks towards core, but HCBS is still available. So you want to make sure that all of your members who are HARP enrolled are offered HCBS core services, and you want to make sure that you want to complete that HCBS core service form, and that's going to be initially and annually. So when you have someone enroll in the program, you want to make sure you're offering services, and then annually thereafter if they did not engage. At minimum. So you're going to be doing that at minimum of annually. However, if there is a significant life event, that changes. Again, anyone can change their mind at any time. And then those services can be offered and you can get them referred out. Does anyone have any questions with HARP? Okay, you can go to the next slide. Next, we have our Health Home Plus policy for SMI and AOT. Annual review, no edit, so everything is staying exactly the same. You want to make sure that your members have a qualifying primary diagnosis of an SMI condition, and they meet their eligibility category every 12 months. You have to make sure that you're noting the problems correctly in NetSmart. You have supporting documentation to support that SMI condition. Any condition that makes them qualify for Health Home Plus under SMI, you will find the corresponding code rate in the policy because it's not any mental health condition. It is a specific subset of mental health and behavioral health conditions. And then you want to make sure that you are checking eligibility every 12 months. So whatever category you are billing under, that is what you have to have supporting documentation for, except homelessness. And then if that is the case, it must be on the problems list under social health problem and must be addressed in the plan of care. There are no updates. That was just a reminder on those two things that we most often see some issues with. Does anyone have any questions on this policy? Okay, you can go to the next slide. Next, this is applicable to our children's population only and only applicable to those youth that are enrolled in HCBS. This is an annual review, no changes. So it's HCBS authorization for fee-for-service members only. This is just, again, annual review, no changes. The HCBS provider is responsible for submitting their authorization in IRAMS. So the provider is the responsible party for once a referral is submitted and that kiddo has been connected to service, that HCBS provider will put their authorization in IRAMS, once in IRAMS, and approved. So it must be approved, and the Department of Health will approve and or deny or partially approve that service. The Health Home Care Manager can update the plan of care with frequency, scope, and duration. Do not update frequency, scope, and duration in your HCBS plan of care because the provider emailed it to you. It has to be in IRAMS before you move forward with that update because what is put in email may not be put in IRAMS. And we actually had our first denial of HCBS services, outright denial. It wasn't partially approved. It was just flat out denied. We have never had that before. So if you do see that, please reach out. I'm working with that CMA right now to make sure that that kiddo can file a fair hearing. And I've also submitted some questions to the Department of Health. Does anybody have any questions on this policy? Okay, go to the next one. Next, our home with youth services. So this is for our kiddos that are not in a self-consenting population and are under 18, but need support from Health Home. This is an annual review, no changes to this policy. So if you do not have an identified caregiver and you fall into that homeless category, you are not self-consenting, but you need support and you want to enroll in Health Home, you would follow the guidance in this policy. Again, you would complete that attestation form, just saying that the consent has been discussed with you, what Health Home is. You will have the member sign that attestation, and then you will complete the 50/55 consent form for those kiddos. Does anybody have any questions on this policy? Okay, you can go to the next slide. Next, we have incident reporting. Again, annual review, no changes. You want to make sure that you are submitting your incident within 24 hours of Health Home Care Manager notification. That doesn't mean 24 hours within the time frame that the incident happened because you may not have been aware of it. But as soon as that you are aware that an incident has occurred, you want to make sure that you're getting your incident reports in. You can do that directly in IRAMS, or you can submit a paper version of the incident to the Health Home inbox, and then someone from the Health Home will enter that incident for you into IRAM. So there's two ways to get those incidents in, and you want to make sure that you're doing it within 24 hours of notification. Any questions on this policy? Okay, you can go to the next slide. And for our last policy today, we have the transfer process between Health Home Serving Children and OPWDD comprehensive waiver. So this is only for kiddos that are in Children's Health Home under the HCBS waiver under DOH, and they want to move their services over to the OPWDD comprehensive waiver and move to a CCO. So this is a very, very, very small subset of our population. This is an annual update. There were no changes between in this policy. And you want to make sure that you note that the transfer process between waivers is very different than the transfer process when we just send a mainstream health home kiddo to OPWDD. This follows a very different path, and that is all laid out in this policy, which I'm not going to go through because it happens so infrequently. But does anybody have any questions about this policy? Alrighty, that was the last update I had for this month. Again, August, we'll start to see a lot of our policies that do have some changes coming up. So it will be a little bit more in depth in August. But if you have policy questions at any time, you can email me or you can email the health home and we can get you an answer.
All right, thank you, Jessica. Okay, so NetSmart attachment documentation issue. Just wanted to touch base on this this month again. Further follow-up. Just recently, in the last week or so, we had reached out to the supervisors throughout the network, provided an update through an FAQ and a root cause analysis that NetSmart had provided the lead health home in regards to the documentation loss issue, and then some frequently asked questions that we had received across the network from various supervisors and organizations. I'm going to provide that FAQ and root cause analysis to the network along with the slide deck today after today's meeting as well, just as far as providing that to everyone so that you all can have that. Again, I gave this to the supervisors prior, but I wanted to get this out to everyone on top of that, just so that you could all have this information as well. It's just going to give further information that we had gotten based on questions and follow-up from NetSmart, based on the documentation concerns and follow through that we had gotten from that. To this point, we have taken and gotten recovery from over half the network from documentation, and we really thank those providers that have gotten that documentation back to us. We've got about a 19% of documentation that has not been found for those organizations that have gotten that documentation back to us. So I would say, you know, based on all the providers in the network that have gotten back to us, having 19% of that documentation not being back, you know, that's where we're at the moment. So out of half the network, about 19% of the documentation has not been able to be found in the reports that we've gotten back. So we're continuing to, you know, encourage providers to continue to try and get information as much as possible back into the systems. You know, DOH has really encouraged us to have providers try and look for information as much as possible. That's the best case scenario. You know, that is at the end of the day, if claims are being looked for and OMIG does come and audit, DOH does come and audit, they're looking for documentation to be in place for claims to be paid out, especially if it's billable related documentation. So we're encouraging as much as possible for that to happen. So we do appreciate everything that's been done to this point. We have encouraged organizations to clock their time, if you will, and provide that back to us, which agencies have been doing, and providing that information to us. So we've been taking that information and bringing that back as well, as agencies have been giving that to us. So we appreciate that as well. So that's what we have at that point as far as the documentation effort. DOH also has not given us feedback at this point on any documentation that will or will not be acceptable as far as what they will dismiss or not dismiss on a file, or what's not willing to be removed from a file. So we as leads have gotten together, I think I mentioned in the last office hours, had presented a document to the Department of Health of all the case record, if you will, of what an individual is responsible for in health home, what has to be presented in a case record, and ask them to look at that to see if there's anything that they would be willing to find to be exempt from that. They said they would take that back, look at that, and get back to the lead health homes. They to date have not responded to us. We're supposed to be having another meeting with them around this time. They said 2 to 3 weeks. We've come to that 3-week time limit. They have yet to respond to us. We're expecting at any time for them to get back to us with a meeting with their answer on that document request for some sort of response. So that is something we're waiting on still from the Department of Health.
So Travis, this is
Yes.
Jackie Jackson.
Yes, Jackie.
That was very wordy, very confusing, and very long. But from that, my question is this. So if we get audited again and we're missing records based on the records that were lost, are you saying that we're responsible for that?
What I'm saying, that the instruction that the Department of Health put forward to the leads is if it's billable related documentation and it's missing, there can be overpayment potential, is what we were told. Yes.
Wow. Through no fault of our own. Okay.
So what we're at this point doing is encouraging, and everybody's been diligent in doing this, is trying to get the documentation back in place to try to prevent that from happening. The other thing, though, we disclosed on July 1st to OMEG, because we're required to do that, the documentation destruction requirement through OMEG to disclose that this happened, and they accepted our disclosure. And the next step that we're going to do is we're going to continue to disclose as organizations are submitting documentation and putting stuff in. We're going to continue as an organization as a lead, to disclose along the way everything that we're able to find and show that we're doing our due diligence as a lead to be transparent to OMEG, so that we're being very clear about this process, so that they're well aware, because there is an ability through OMEG to look at this and understand that we're doing everything we can as a lead, as an entity, to be transparent about this process, because this is out of our control. This is out of everybody's control. This is something that NetSmart, this is their failure. So we're taking this step. We're being very clear that we're being transparent. We're putting our best foot forward, so that OMEG is, being well aware that this is not an intentional thing that was done on any provider's effort or anybody's effort to be malicious or malintent. So that is something that we're continuing to take steps to be proactive on as we go through this process, to be transparent.
Travis, this is Debbie from Glens Falls Hospital. What about ownership from NetSmart? Are they open to, helping with the cost? If it gets to that point?
We're continuing as a lead, as an entity, as an organization to discuss all options, and we're looking at that. As far as those details and the granulars around that, I can't get into that part of it at this point, Debbie. I can tell you we're looking at all of those options and discussions.
Okay, thank you.
Yes.
We
Travis,
have a
this-
couple. Oh, I'm sorry. Go
Sorry.
ahead.
Sorry, I had my hand up. This is Brandy. Hi, Travis. How are you?
Good, Brandy. How are you?
I'm fine. And speaking of transparency, I have a question or concern I'd like to address. Back in August, several of our CMAs experienced a NetSmart, a day where NetSmart went down, and we got that error message that said roads closed, Pizza Boy. And I find it very ironic that after that happened is when we lost all of this documentation. Have you thought about the correlation between that and when all of those missing documents happened?
August of last year you're referring to?
Yep.
I know they did the server update last fall. I don't know if there's, I don't
It
know.
was
if
right
there's a-
after that we started having all of these issues, and that's from September 1st to now is when all of those NetSmart documents were lost.
I mean, you're raising a point that we can definitely bring into the discussion, Brandy, for sure. I don't know if that's correlating directly. I can't personally speak to that, but I mean, you bring something that can be brought into the discussion if it hasn't been already, for sure.
We do have a couple questions in the chat. One question that a lot of people have, it was liked a few times. It says, what will happen if we are unable to find these documents that were originally uploaded per chart compliance that NetSmart lost? Second part to that is, what was the purpose of tracking our time spent to re-upload all of these missing documents? Will we be compensated for that lost time that has potentially impacted delivery of services and billables?
Yeah, so that part of the question, so AHI is asking organizations, and this is coming from our executive team, to track time. We've asked supervisors to do this so that we can press NetSmart ultimately to reimburse for that time. That's why we've been asking organizations to track that. So that is something that we're looking at and we've been in discussions about. So that's the information I have at this point. How that's going to be filtered through and gone about. I mean, those discussions are a little bit above my status, but I know that's something that the organization is definitely intending on and asking organizations to bring information forward because of the fact that that's what we want to do, because of the fact that we know this is a tremendous burden on organizations and limited resources are limited. And, this is not something that should be going to agencies to begin with and having this burden. And we're clearly understanding of that.
To follow up on that question, they're asking reimburse who? AHI or the CMEs who have been responsible for taking on this burden?
It would be reimbursing the CMAs.
We have another question that says, what is your guidance for CMAs who did not store documents in a backup location?
Well, I've had other CMAs ask us. I think that's a difficult scenario because I would ask CMA supervisors to refer to their health home services provider agreements and look at that language. Your agreements have language that you should have documentation, backup for medical records for 6 years outside of this software that we have through NetSmart. So you really should have a health record medical system of some sort within your organization. It shouldn't be just solely relying on NetSmart Care Manager as the sole entity of source. You should have medical records backup in your organization. It's in the Health Home Services Agreement. There's literature in there. And I would refer back to that arrangement, that agreement with your organization with the lead health home that has been executed.
To follow up on that question, Raquel is asking, what about documents that are from staff that are no longer employed and they cannot get back?
I would refer back to your really looking at your internal process with your supervisor and your team. I can't speak to you what your internal processes are, how's your information. That's a tough answer to give. I don't know your process.
We have another question in here that says, where is the responsibility of NetSmart to have a backup system for all of the missing documents that have PHI included in them?
Can you ask that one again? I'm sorry.
Yep, it says, where is the responsibility of NetSmart to have a backup system for all of the missing documents that have PHI included?
That's a good question. We've been asking a lot of questions to NetSmart. They've been answering as we're going. We can bring that back as one of the questions that we've been adding to the numerous ones that we've been bringing forth.
Next, if we cannot recover a signed plan of care, should we have the plan of care re-signed? If so, what date should we use? The date of the original signature or the actual date it was re-signed?
We should never backdate.
Next, there's a question that says, Travis, can you please share the document that you're referring to about the responsibilities of CMAs to have a backup system?
Your health home services agreement, you should have a copy at your organization. If not, you can reach out and I can send it to you. The supervisor.
There's a follow-up question to the plan of care question. It says, understanding not backdating, but we have an upload with the date along with a note.
What was that one, Jessica? I'm sorry.
Yep, so this is to go with that plan of care question. They said understanding not backdating, but we have the upload, I'm assuming the time, date, and stamp in the original system with that date along with a corresponding note.
Yeah, we're going to have to clarify on that one because we're trying to work with NetSmart right now on them doing some sort of an attestation in the record. And we're waiting for them to get back to the leads on this one. I think we mentioned this on the prior office hours as well. They're coming up with a template right now to get back to the leads, and there's follow-up for them to get a meeting back together with us to review that template. And it's supposed to be universal across the health homes for those organizations that have more than one lead, so that when you go into a record, if you're in more than one lead, you'll have the same format, if you will, and it will ultimately have the same layout, and it's going to basically attest that that plan was in place, along with that time, date, and stamp of that skeleton, if you will, of the fact that it was in there originally, but it was no longer there now. When you go in and see that that it was deleted, but that attestation is going to show that there was one there. So we're waiting to see for that to come back. So based on what that comes out, then we can go from there. Right? So I want to hold a moment on that one a little bit longer, if you would.
There's another question in here. It says, if the expectation of the CMAs is to be backing up medical records, there needs to be a policy and procedure that points to that expectation. What documents need to be backed up / all documents ?
I don't know if we necessarily need a policy if it's in the health home services provider agreement. So I don't know if I necessarily agree with that, but we're waiting to see back from DOH what their response is on this answer on the documents. You need to have medical records back up for 6 years, is what our agreement says.
Travis, I think there has to be clarity on what that means, because I think that the spirit of that ASA is that if for any reason we're handling Medicaid data in our own systems, as if, for example, if we're downloading a care plan, that we're saving that and backing it up, right? So that's if we're exporting it from what is the record that we're, by way of compliance, expected to use. I think that the way that you're defining the ASA is really out of scope. I think that just the nature of the health home model is that we're all using one EHR, and that is where we hold our documents. So I think that I'm a little worried, to be transparent, that we're saying that the CMAs are responsible to back up medical records, because then where do we draw the line? I mean, why would we then document in NetSmart just to be expected to have it in another location? So I think that for us, and being, again, very transparent, we didn't back up documentation that wasn't our protocol. We used NetSmart as the record of choice. And so my concern is that, one is, if there is this expectation, then I need to know very clearly and concisely what documents we're expected to back up. Thing two is, I need to know how you want us to proceed in a very detailed, concrete way for those records that we don't have. We will do whatever we need to do, but I really am looking for clarity on what the right approach is.
I appreciate that, Ann. Excuse me. I think the concern lies, we have Medicaid records and data, and I think you can appreciate this, being in this field for the number of years and the roles that you've held in particular. Having backup documentation for Medicaid claims is paramount, and having that in place, shouldn't just rely on one record to do that. And I believe that an auditor would tell you that all day long. So you need to look at it from the lens that, and most every organization that's responded back to us has had backup. I mean, you're an exception, to be honest with you, thus far, since we're being transparent. And we really want to not be in a situation where you're not going to be in an outlier scenario where you're not going to have a dynamic where you're not gonna have a backup where you have the ability to have another option to get information into a system if something goes wrong. What if something fails? I mean, how did we ever know this was gonna fail? You know, you gotta have plan B. And this
But
is,
wouldn't Plan B, I'm sorry, this is Raquel, and this is just blowing my mind. Wouldn't Plan B be that NetSmart is responsible for a backup? Like, I guess I'm really confused because the platform that we are supposed to use is NetSmart. So for us to have another platform, I'm just, this makes no sense. We are literally in the land of opposites lately.
it
So
is
this
the
is
elec-
Sarah Wright. Travis, if I can just chime in here, I think we need to maybe put a little pin in the documentation and the requirements, because I think there's kind of two things at play here. One is that, and we are working with legal and with NetSmart on the implications of this, as well as how do we handle it with DOH and potentially OMIG. But NetSmart, they did have a backup, but their backup failed. So that's where it is a failure in their process. And there is a process that, as Travis mentioned, we're working through to document that with OMIG. It's unknown for all of us today what that means in a future audit. So as we have more information, we'll certainly share that. I would say from the lead perspective, the best feedback that we can give today on, I think there was a question about, what do we do with documents that don't exist? And we don't have a backup that we've been able to point to kind of pull back into the system. And I would say from that perspective, as you have interactions with clients, and I understand that there are some past clients that maybe aren't current clients, so that's going to be a different situation, but to go recreate documents. And I would put today's date, as Travis mentioned, we shouldn't backdate, but you could in the notes in the system, or even, add notes on the file that reference, it's dated today, but this is a document that was lost during XYZ destruction. So we are working with NetSmart. We were trying to see if we could put kind of a blanket in the system to identify all of the documents and note that they were lost. This kind of bridges that gap in the interim without a future path forward. And we recognize that's a huge lift for every organization to go through and recreate documents. And that's where tracking your time is coming into place. So we've got kind of a few different balls in the air, if you will, here. And asking people, again, I know it's one more thing to do, but tracking the time is a little bit of a proactive step that we're working with our legal and through discussions with the other health home leads on what does this mean going forward? What are our future actions? And while we don't know today what other legal ramifications may come between AHI and NetSmart, or kind of the other leads and NetSmart, we want to have all of that documentation, because there may come a time that we are going to request or go through some sort of litigation where we are seeking at least the time everybody has put in to recreating and documenting and looking for details. So I know it's kind of one more step. And I would just kind of keep like a running tab, and then we'll be collecting that information for like a next step or continued steps in discussions with NetSmart on what is the impact to our organizations, both direct and indirect. And that's, depending upon which role you play, it kind of feeds into both. It's a direct impact because staff are using time to now go get documents that were already there, meaning we can't document new information. And it's just the redundancy. So unfortunately, a lot of this is in discussion and all great questions. We have asked and talked about a lot of this with even the other health home leads. We just have not received clarity from either DOH or OMIG at this time. But we do have kind of all of these things, and sometimes we're asking a similar question from a different angle, and that's totally fine because we want to make sure as this evolves, that we are asking all of the questions at the right time so that hopefully we have answers. But unfortunately today, the government has been kind of hands off with well, we need to see. So I know it's frustrating because we're still so uncertain on what this potential future impact is, but we're still seeking and gathering information to hopefully mitigate and have better plans going forward. And transparency, I think that we've shared this before, we are also super frustrated with NetSmart. We are looking at alternatives in the future because we too feel that this situation was unacceptable and has put, everybody at risk, and extra time and energy spent in an already complex process. And, people's time. We have a lot of organizations that don't have the bandwidth to do the work today, no less do extra work. So, we are looking at things internally to see what is our ultimate path moving forward, because we are in agreement that this situation has in many ways been a failure beyond just the loss of documentation.
Thank you, Sarah, for the additional insight. Anybody have any other questions around this?
There are a few more in the chat. Someone is asking, do we have a guarantee that there wasn't a PHI breach? If there was, who would take responsibility for that breach?
So NetSmart has put in writing, and it has gone back through, we've put that through our council. It's gone back to the Department of Health. They've actually asked for that information as well. They do not deem it a PHI breach. We also asked for in writing if this was a disaster recovery effort on their part. They did not deem it as part of a disaster recovery because their system did not go down. It was only a partial component of their environment that was impacted, which they were able to effectively work through and operationalize in an effective manner in their eyes. So they didn't have to effectively implement the disaster recovery effort on their wide-scale plan. So that's all been in documentation that they provided, that they put forward. And they did not in any level feel that it met a PHI nor a disaster level type of effort.
Then we just have a comment in here. Someone saying, should we have paper charts for the last 6 years? And then someone said, when we started with another health home lead, they told us specifically not to keep paper charts because NetSmart Care Manager would keep records. So again, more back to that conversation about keeping paper records. So more to come on that, and then Travis can get you your agreements that you all signed. There is another comment in here about the upload, signature, all of that date. So I do want to go back to that because someone is commenting. So to be 100% clear, you, the lead health home, are directing us, the CMAs, to put the current date of upload in when we are re-uploading document, that the original upload per chart compliance. So I just want to go back to that. When you are re-uploading your documents, you can put and should put the original date of upload. So if I had a document signed in, I don't know, January 1st of this year, and I uploaded it and that 5055 was lost in whatever, if I have that original 5055 still, I would re-upload it and I would pick January 1st of this year because that's when it was originally uploaded. We also have that original upload time, date, and stamp in NetSmart. We're not going to get rid of that because that shows that that document was there at the time when it was needed. When you upload it, put the actual date it was completed on, and then you can also write a note. I have been doing this internally because I also had to have my team find thousands of documents. I would put DOH 5055 originally uploaded on, and then I would put that date. When we get into backdating, let's say you lost your 5055 and you don't have a backup, what Travis instructed us not to do was not have a 5055 completed, because that's something that you are going to have to refill out because you do need that to do your work. Don't backdate that to January 1st of this year. Use today's date. So use 7/21/2026. We know that that document existed in there on January 1st because we have that time, date, and stamp in the system. At the bottom top, somewhere on that 5055, you can make a note originally signed on X date, lost in NetSmart error. So we don't want to backdate things that we're having re-signed, but absolutely upload them with using the date that it was done, because we have that original time, state and damp, that time, stamp and date. Someone is saying we have an email stating to use the current date. Some of our uploads have the re-upload as opposed to the original date. That's fine. The dating component isn't a huge deal because we know when that original document was uploaded. So if you found, your 5055 from 3 months ago and you use today's date, that's fine. When we open the document, because it's the original document, we can see the date it was originally signed. And then I can also see when it was originally uploaded, because we're leaving that audit trail in the system. So it's not necessarily wrong to use today's date. So you can use the original date of upload. You can use today's date. The one thing you don't want to do is, if you have to have something re-signed, backdate it, use the current date, and then just write a note as to when it was originally signed and originally uploaded. And we have that audit trail so that we can verify.
Thank you, Jessica. A couple of things I wanted to mention. So if you're interested in your Health Home Services agreement and you don't have a copy, please reach out to me, because I'm not just going to send it to everyone, because I know some of you have them. The other thing is, in consideration of the medical records discussion, I know that that'll be to be continued. It doesn't necessarily mean paper copies. People can scan them, have them on electronic files. So, just, it's not keeping a paper copy trail for 6 years. So, but just wanted to put that out there. But anyhow, we'll move on. Any other questions before I move on, Jess?
No, that took care of the chat.
Okay, thank you.
I believe so. There's
Okay.
one question in here. I'm sorry, I missed one. For employees that are no longer employed with us, should we document this in each of their client charts? That was Deb from Glens Falls Hospital, so I'm not 100% sure what you're asking about documenting, Deb. So I don't know if you want to take yourself off mute and ask. I can just respond to her too. We can move on. Thank you.
Okay, yeah. Plan of care audit, just wanted to let folks know, we did let the supervisory group know. DOH did give us an extension for our plan of care audit beyond the June 30th date due to the document destruction issue through NetSmart. We did ask for an extension on that audit timeframe just because of everything that was going on around that. They gave us an extension on that, so that allowed us to give folks time on the plan of care audits. And so we extended that to July 31st. And it's allowing us to work on the self-disclosure timeline a little bit differently than what we were working on originally, which is good. And we did start that process. We're been researching with the managed care organizations on their particular disclosure processes versus, because every MCO is different and how you have to send in your self-disclosures per MCO. And then OMEG, the fee-for-service Medicaid disclosure process, has one way of doing it. United Healthcare's got their way of doing it as MCO, Fidelis, MVP, and then so each one's different as far as how they're doing. And so we've researched that on the finance side. For those organizations that have signed off on their PDF, an agreement of what they believe and what the health home believes, an agreement of what the claims are for overpayment, that have had their audits reviewed and completed. What we're going to do next as a lead is we're going to start looking into those disclosure process, whether it's through the MCO for those particular claims or through OMEG, through the fee-for-service Medicaid. And we're going to start to go through and disclose those batches. So that'll be the next step. So the lead's going to start to work with the finance team on that in the next couple of weeks. For those organizations, for those PDFs that have been signed off. So we'll be in touch and knows on those next steps as we start that process and start getting it going. And then I don't know, Sarah, if you had anything else you want to add on that, but that's where we're at this point. We're continuing as a lead to finalize audits. We're trying to work through them as fast as we can. It's a small team doing it, so that's part of why it's taken a little bit. We had the extension, so folks have been finishing up as well on the CMA side with the contemporaneous note stuff. But our goal is to get through them as quickly as we can, get them finalized with the PDFs, with the CMAs remaining. As I mentioned, and then keep pushing through to get that done in the coming weeks with the remaining CMAs. Sarah, did you have anything that you wanted to add on the disclosure process at this point?
Not necessarily on the disclosure, but just, to reiterate the appreciation. I know that it has been a lot, and for many of you, duplicate work, because we completed the audits and then we found out the contemporaneous documentation would be allowed. So people had to go back through. So we recognize that it has been a huge lift in addition to all of the NetSmart data issues. But if you could continue to push and get that information back to us so that we can come to agreement. We do want to make sure that we disclose at this point as quickly as possible to be within that, 60-day notification that is required. But we did share with DOH that, some of the delays are just simply manpower in getting through. That mostly began with the lead. So we understand some of you just received the information only a few weeks ago. But as you have additional questions, we can go back and forth, and come to agreement on, what do we believe the disclosure should be. And we're going to be doing that in 2 waves as of right now, just because some of you have already completed the disclosure. We want to make sure that we timely file, but also want to reduce some of the administrative burden by doing it organization by organization. It's easier for us to kind of group things together. So we are working with the MCOs and fee-for-service Medicaid on how to do the disclosure and the take-back process. At a high level, what we have talked about is once we do the disclosure, we will be sending potentially an invoice out to organizations to make payment within 30 days. And absent payment, we would deduct from future billings. And I know as we've looked at this, some of this process has even, kind of morphed over time from our perspective, as we wanted to make sure that the volume of takebacks compared to weekly payments wasn't too overwhelming for organizations. But fortunately, with the addition of the contemporaneous documentation, we saw some significant improvements that we don't think will, so to speak, bury organizations financially. Although it's never pleasant having take-backs, we're in a similar position, but want to make sure that we can, kind of keep this clean administratively. So as of right now, the plan would be you'll get notification when your organization has been disclosed, and we will work through the take-back process and notify you likely via an invoice of some sort, and be tracking that outside of the process to the extent possible. And then after, 30, 45 days, we would offset it from future claims. And again, probably at the next office hours, we'll have more fine-tuned information as we start to walk through specifics, but just wanted to give everybody a heads up on kind of where things have been moving as the process has been unfolding.
Thank you, Sarah. Were there any questions around this topic at the moment?
So we don't have any questions in the chat on this topic. Deb did just come back and with clarification, and she's asking, since she had 2 care coordinators leave, I'm sorry, back to the uploads discussion, for missing documents, should we have them enter a note stating the document could not be located? So this is something that we didn't discuss when we were talking about the missing documentation. You do not need to go into each of your records and put a note in. We're actually working with NetSmart to put in each record that was affected by this error. We're working with NetSmart to have some sort of system notification. So when auditor goes in, they know that X documents were lost. We're just trying to come to a consensus with the other lead health homes that have been affected on how we want that notification in the record and really the language around that. Once we have that finalized, every record that was affected by the data loss from NetSmart will have an automated notification in there. So you don't have to worry about going in and individually charting in any of those records. And then we did have a comment that came in that says, respectfully requesting guidance in writing that outlines expectations for medical records backup with specifically what portions of the record and what steps to have us follow for document recovery. Having this in writing will help ensure that we are aligning with your expectations. So that was just a comment around having backup documentation on hand outside of NetSmart.
Okay, thank you.
And that's that takes care of the chat.
Okay, thank you. All right. All right, so continuation around the compliance concern, just laying out that, again, just the time frame. We just went over a lot of this stuff. Sarah and I just touched on the process that we're going to go into next for a number of the organizations that have finalized the PDF review with the audit itself. And we'll get into that piece as we get into the disclosure process. So we appreciate, again, everything that everybody's done going through this, because it has been a huge undertaking and time consuming as well. The actual redesignation itself, we're going through that right now. We haven't gotten any feedback from DOH this month on this. They haven't reached out once since the audit started on July 1st. It's been very quiet. So I do want to thank everyone that has been reached out to earlier in the month on getting plans of care in that were reached out to. So thank you very much. We got everything in for those that needed to get uploaded. So I just waiting to hear. That's just a matter of waiting at this point. So that's the status on the actual audit. Everything that we needed to get in is in, and we're waiting to hear on the response. So we'll let you know as soon as we hear. BTQ. So a couple things at BTQ I want to give updates on. There's an email, support desk email here, healthhomesuppport@btqfinancial.com. So anything as we move forward for effective dates of 7/1/26, should be sent to this support email for BTQ. So this is related to like support questions for BTQ, but anything for MAP segments. So anything for NetSmart MAP related questions for newly enrolled members. We encourage folks to reach out to BTQ on this for anybody for 7-1 moving forward. So anything around, anybody enrolling for new members. We encourage folks also for making sure agencies, when you're putting people into MAP outreach, make sure you put them into outreach status. Most organizations are doing this, but some folks are having some information is not fully getting in correctly when they're putting folks into MAP. So Caitlin's working with those organizations over the next handful of weeks. We're asking that by September 1st that every organization is ensuring that as you're going into MAP and putting any new person into MAP, that they're going into outreach status as you're getting them into MAP and getting all their information put in completely, so that when BTQ goes and they're pulling that information from MAP over to NetSmart, because they've taken that process over as of July 1st, that information is getting pulled correctly. So over the next handful of weeks, throughout the rest of July and through August, Caitlin's going to make sure that any of the issues are worked out with that, and working with each of the organizations. But as of September 1st, we want to make sure that the agencies are got that down as they're entering folks into MAP, and outreach status is the status that folks are entered into as any new folks are put in. So I just wanted to pause quick to make sure if there's any questions around this particular slide around MAP segments, NetSmart, for any new folks for the 7-1 moving forward. Excuse me. Okay.
No questions. Oh, there's no questions about BTQ. We do have a question about redesignation. If we want to
Okay.
go back to that after you're done with the BTQ slides.
Okay. I had one more thing with BTQ. So effective the next disbursement report. So there's a disbursement report that a health home sends out. It's generally on a weekly basis. The next one that's going to come out, that's going to be sent out by the health home, likely going to be next week. It's going to include payments related to the 7-1 claims. It's going to be a combination of claims processed through Millen and BTQ because the switchover started as of 7-1. So it's going to have information in this email that's going to come out from the health home that's going to look similar to that noted below on the slide. So I just wanted folks to get a snapshot of it now. The note's going to go out to the folks that are going to be generally going to get that email, but it's going to have detail that's going to include dates of service prior to 7-1 that were processed in Millen, but it's also going to have claim details for service after 7-1 that'll be emailed to your agency designated BTQ contact, and it'll have total payment and reflects combined payments from both data sources. So I just wanted to make sure folks were aware of that. So supervisors out there on the call right now, if you just want to make sure that kind of gets back to not only you for your purposes, but for your BTQ contacts for that this is going to be coming forth on the next disbursement report information as that goes out. So it's going to be a combination of Millen and BTQ information process on that next report that's going to come out in that email. So just to be note on that. And if there's questions, if it gets a little confusion when that comes out, just reach out back to the health home and then we can make sure that those get answered. But we just didn't want folks to be like, what the heck's going on? Because the transition happened, obviously, and then it's just going to be claims coming through from two things for a little bit here. So Jess, you had question come through from redesignation?
Yep, Caitlin's also just commenting that if anyone has any questions about inputting segments into MAP, to reach out to her and she can schedule a meeting to help you guys through that.
Oh,
Thank you,
okay, thank you,
Caitlin.
Caitlin. Thank you.
And then back to the redesignation, someone is asking with redesignation, what happens if redesignation is not approved by DOH?
We're expecting it's going to be, but we're 95% is our threshold. That's what we're told is the threshold at this point. We're expecting that we're going to meet that. If we don't meet it, then we have a chance of losing the redesignation. That's the answer.
And someone is asking, and what does that mean if you lose redesignation?
If you lose redesignation for the children's redesignation, that means you would lose the ability to provide children's health home services status as a lead, which would mean we would no longer as a lead be able to provide children's health home oversight, which would mean as a provider, you would not be able to provide health home care management services under AHI Health Home. So you would lose that ability under us as a lead.
So just to piggyback off of that, like Travis said, we do have that 95% threshold. Based off of our initial review, because this is something that we have been watching, there are some CMAs that did not comply prior to that February 2026 start date of the new process. They didn't listen to that guidance that was put out in October about making sure that your signature date matched the date that the plan of care was completed and finalized in the system. So we did have some non-compliant CMAs, and everything is looped together as a group. So we have some CMAs that were 100% compliance, other CMAs that did not listen to our guidance. So we're not going to be at 100%. I do believe, based off of what we've seen, that we will fare well. Overall, from the Department of Health, when we did have our meetings, we did ask them, if we can't meet that 95%, what happens? This is kind of an odd situation. Under normal circumstances, if you are on provisional designation and they come out and they re-audit you and you perform poorly, they will pull your designation. With that being said, this is not a normal provisional status that we're in. This is really for one area. They're not looking at all of our records incompleteness. They're specifically looking at this one particular area. So when we did ask them, say we had 94%, we don't hit 95, what happens? They really did not give us a straight answer. They did not say flat out, you will be de-designated. Can they do that? Absolutely. They do have the power to do that. That is in our agreement that we signed. It's in their redesignation policy. However, we are in a very unique position with some other lead health homes, with a number of other lead health homes. One of them being the largest children's health home that serves the most children all across the state. So they were not going to give us a straight answer. They didn't really have a straight answer. I do not think, it will be a flat out de-designation. It absolutely could be. They have every right to do so. But we did ask those questions and they did not flat out say you will be de-designated. So as we learn more information, we will let you know. I do think we will be close to that 95%. Again, we're not going to be 100 because some of our CMAs did not follow the memo out that was discussed in office hours, starting back in October. Some of you followed it very well, but they will look at us across all CMAs. So we will keep you posted on all of that as more on folds, but we, like Travis said, we have not heard from anybody through the Department of Health through these first 21 days of July. So we have really no feedback to kind of gauge where we're at this point.
Yeah, they were, I mean, we performed so well over the last few years as a lead, both in children's and adults in our prior designations and outside of this plan of care audit issue, we performed extremely well in our redesignation this last fall. They're looking at our system. Did we improve on our system? And as I mentioned, when the question was first asked and I started answering, I think we did well. Can they pull it? Yeah, they can absolutely pull it. I think we did well though. It's just a matter of what stance are they going to take at the end of the day. I don't know how hardline they're going to be. We don't know I think that if we're close, they'll probably give us some flexibility. Absolutely. If we do poorly, then they have discretion to do whatever they want to do. I mean, that's the reality that we're going to face, but I don't think we're in that boat. I think we, from our data review, from looking at what came in and the dates and alignment from people getting signatures, most every organization overall followed policy and got signatures in timely fashion, which is good. That's what we want, and that's what policy dictates, and that's what we need to have happen. So that was a good thing. So I think we're going to perform pretty strong, but we have to wait to see what the results are. Any other questions, Jess?
Nope, that's it from the chat.
Okay. Anything around BTQ otherwise? Okay. Social support contacts tab, we're flipping over this. Just a big reminder on this, so we don't get errors on plan of care. When that report's pulled, make sure, if you would, please just to fill this tab out as much as possible. Phone numbers, addresses, all get that information complete in here. So when that file's pulled over, that plan of care is not erroring out. There's still instances where that's occurring, and a lot of that's due to that this tab's not getting completed. So just a friendly reminder for folks, if you would, please. And then just wanted to keep this series of slides in here. I know we went over it last month, so I won't touch on each one of them, but just the new 5055 consent form. September is going to be going into full swing for any newly enrolled members. And it's a brand new form, as folks know. Please start using it. You could start using it as of last month if you so chose. And September 1st is when it's got to get going. And it's an additional page due to the new format. Got a lot of new language in there, and looks pretty.
One thing I just want to point out with the new 5055, because we did have this question come in through the email. One of the main reasons for the updated 5055 is because they are moving towards more a condensed RIO language. So you won't see a specific reference to HCSNI anymore. They're moving towards just language around RIO and the SHINee, and that is consent for HCSNI. So you will not see HCSNI explicitly called out, and that's because they're changing the way that you consent. Not really changing the way we consent, let me word that better. Changing the way consent flows for your RIOs. So that's all of the RIOs individually. So that's why they move to broader language. So you will not see HCSNI specifically called out, but when they sign this and they consent to the RIO and to Health Home, they're also consenting to HCSNI. It's one and the same. So I just wanted to point that out in case anyone else had questions on that.
Thanks, Jess. It's a good point. You also will be having to update our consents policy too. Just DOH is going to be dropping an update on that policy shortly due to the
Yes.
changes.
That is correct. There will be a new informed consent policy coming out. We will be getting a new policy from DOH.
And then the link to that new form for folks, if they so choose. And then that was it for today from us. Did anybody have anything else that they wanted to discuss?
We have a question that said, is there a suggestion for adult members who do not wish to list a social support contact? I believe a while back we were told children needed one, but the adults did not. Yes, Kennedy, that is absolutely correct. So that social supports tab is unique to non-self-consenting youth. So if you are enrolled in Children's Health Home and you were not self-consenting, so 18, basically if you did not sign a 50-55 and your consenter type makes you have a 5201, those are the folks who need to make sure that the consenter is listed in the social supports tab, because that is where that information pulls when we extract that plan of care out of NetSmart and import it into MAP. So one of the things that you're going to see now that we are moving forward with BTQ is they're processing more than just our billing files. So that's why we were talking about like, hey, if you have a problem with the segment, reach out to BTQ, because they're the ones that are doing those files now. One of those files will be the plan of care file. One of the errors that we see a lot for kiddos is we have it reject because that information, so the address, phone number is not pulling, and that information pulls from the social support contact. So as we move forward with BTQ, those errors will fall on the CMA to kind of resolve. So one way we can get ahead of that is to make sure that that information is captured in your social support tab. So again, if you're working with youth in Children's Health Home and they are not self-consenting, so they've signed that 5201, you want to make sure that that primary guardian is listed in their social supports tab and that their information is complete in there. So that means that your plan of care will successfully export out of NetSmart and import into MAP, and you won't get an error. So that's what that was referring to. Any other questions on anything? Nope, no worries, Kennedy. I don't think we explicitly called out children, so that's no worries. I'm glad you asked, so everyone knows it's just applicable to kids. All right, that's it for the chat. Oh, I think Charles has his hand raised.
Sorry, a real quick question for you. The new 50-55, I know my staff asked me this. On the first page, it talks about statewide psyches tab choices, the UAS and why we still need to get people to sign a psyches consent. This isn't taking place of that, right? I know it reads a little kind of like that, but I assume that we still need to get psyches consents for people. Is that correct?
Yes, I believe,
No.
yes.
No. So psyches, so on your 5201 and your 50-55s, psyches and your Rio/HCSNI consent is in those consents.
Okay,
You
so that
do
is, okay.
not have to get a separate psyches consent. You do not need a separate HCSNI consent for HCSNI alerts or to access psyches. So when you log into psyches, and you say like, yes, I have consent for this member, it'll ask you what type of consent you have. You can absolutely collect a separate psyches consent if you would like, but you absolutely do not have to. When they sign their 5201, when they sign their 50-55, they're giving you consent to go in there. So that's why you can select this person has signed the health home consent and you can go into psyche. So you do not have to collect a separate consent form for that. The only time you need a separate consent form is if your individual CMA has access to the Hixney portal. So outside of NetSmart, you go into the Hixney portal. That is when you need that separate Hixney consent. If you're just going into NetSmart to view those Hixney alerts, then your 5201 and your 5055 covers that access right there.
Okay, perfect. That's how it reads, but I just wanted to make sure. Thank you.
Yeah.
Any other questions? All right. Well, I thank everybody for their time today. Thank you for all the questions, and I appreciate the discussion as always. I hope you all have a good rest of your day, and we'll talk with you soon. Thanks, everyone.
Thank you.